All right, team. Well, maybe we'll get started with some introductions, and I'm sure a few more people will trickle in. We might have a nice intimate group, which means we'll have a lot of time to talk about all the platforms we're going to discuss. So welcome. My name is Becca Burns. I'm a pediatric emergency medicine physician at Seattle Children's. And I'm working with an amazing group of folks here to work with you all and talk through selecting and using telesimulation, also called distance simulation, resources to engage learners from afar. So I am going to let all of my co-presenters go through and introduce themselves.
Hi, everyone. Nice to meet you. My name is James Leung. I'm a pediatric emergency medicine physician practicing out of McMaster University in Hamilton, Ontario, Canada. From the perspective of this talk, I've been a big designer and use of the VRR, the Virtual Recess Room platform, during the last few months.
Hi everyone, my name is Maybelle Koo and I'm coming from Virginia, USA, where I am also a PEM physician. I also practice emergency medicine and direct simulation for graduate medical education here. And I'm with the ACEP SimBox team, and we've really enjoyed putting together this for you.
Hi everyone, my name is Anita Thomas. I'm also pediatric emergency medicine in Seattle. And very excited to help facilitate this.
Isabella, you want to introduce yourself?
Yeah, I was confused when it's my turn. I was just checking with somebody to find out. I'm Isabel Goes, pediatric emergency medicine physician at Yale, simulation enthusiast, specifically distance simulation. Have been doing it for many years, mostly interested in reaching the global community with simulation. So the pandemic was just something that happened, and very interested in the oversight of what this concept is, foundations of it, understanding the concept of business simulation. Happy to be here.
I'm Kyle Cassidy. I'm a technologist and filmmaker at the University of Pennsylvania, where I help people integrate art and technology into their research.
Hello, good morning, good afternoon, everyone. I'm Elizabeth Sanso. I'm a former Seattle Children's resident, and currently I'm a fellow in pediatric emergency medicine and global health at the Children's Hospital of Philadelphia. I'm part of the SimBox group, I'm part of the Hotkeys group, and I'm an avid user and fan of the VRR and very interested in distance simulation, specifically as a way to bridge the academic medical center with more remote, low and limited resource settings.
Hi, everybody. My name is Lana Bank. I'm from McGill University. I'm a pediatric emergency physician there, and I'm in charge of simulation for our center. And I've been using VRR this year since COVID hit us, and it was a great opportunity and a huge fan of it, actually.
Thank you. And we'll have an opportunity for everyone else joining us to introduce themselves a bit when we do some breakout rooms later. So, all right, I'm going to try to drive this computer, which, as Anita knows, is not my strong suit. So be patient. So by the end of today's workshop, we're going to hope that you're able to talk about 3 different strategies for distance simulation, and hopefully share those with some friends as well. You'll be able to think.
Sorry to interrupt you. Are the slides being shared right now?
Oh, see, it's already happening. They were, let's see.
Maybe that's why I didn't know it was my turn.
There we go. Now you can see them. Excellent. Okay, so we're just reviewing our objectives right now. We're going to ask that you think through sort of the pluses, the things that work really well with these different forms of distance simulation and where some of the challenges might arise. And then we're going to spend some time in small groups thinking through learning objectives and starting to outline a simulation. We have no disclosures. None of us get any financial profit from any of these platforms we are sharing with you. We're very excited for open access resources. And I'm going to let Isabel take it away.
Thank you so much, Becca, for the introduction. It's very exciting to be here with all of you because since COVID, it has been very difficult to not conduct simulations at a distance, right? So I will give you a little bit of background of the concept. maybe some of you haven't used it, so we just want to make sure we get everybody on the same page before we start. Last year, we conducted a survey, a worldwide survey, surveying simulationists across the globe in regards to, are you using distance simulation? And if you are, were you using it before COVID, or is this a new thing for you? Before I start using that term distance simulation all the time, the simulation community has not come to a conclusion of which term should be used. So you can feel free to use distance simulation, telesimulation, remote simulation. We conducted a huge Delphi process to come to a conclusion, and it was about a third, which one should be used. So I'm going to say distance simulation, but feel free to say whichever. So about 28% of institutions were using distance simulation before COVID-19, and then at the time of the survey, which was last September, it was about 70%. So 70%, that's a huge number. So I really hope that this workshop will be helpful to you.
And I think we have a poll that is going to be unleashed momentarily.
So now we would like to know from everyone, are you, how much you are, if you are using distance simulation, and there will be some questions for you to answer. So how have you participated in distance simulation activities since March 2020?
Excellent. We're seeing a lot of people are saying yes. So we look forward to hearing about your experiences as well.
That's great. I see that some are saying no, and maybe especially if you are going to say no, you might not feel comfortable clicking on no. So I will give you a little bit of background. Let me just close this poll so I don't see it. All right, so these slides are compliments to Todd Chang. He developed this pictogram that I really liked as a demonstration of what the concept of distance simulation is. So here you can see a mannequin, an operator, facilitator, and a learner. In a traditional simulation, everybody is in the same room, right? So you have the mannequin lying down in purple, the learners next to the mannequin, operator and facilitator, everybody in the same space. As Liz and I have experienced before the pandemic already, and many others of you as well, is sometimes you might have the learners, operator, and mannequin in one space, and then the facilitator or content expert removed from the scene. So a facilitator could be having a simulation expertise from another country, facilitating from home. Here you can see some pictures that I took doing a distance simulation with Europe, with Latvia, where I was at home just with my computer, and everybody else was in the same space. You can see on the left-hand side my computer screen, so I was able to see two video angles, vital signs, and then on the right-hand side you can see what the participants could see, big screen with my face on it, and we were able to interact that way. So I would consider that a hybrid simulation. Or you could have, like many of us experimented in the pandemic, the learners at home and the operator and facilitator with the mannequin, manipulating certain things with a mannequin. This is also considered a hybrid simulation. Or everybody could be at home at the same time, or you could even have a separation of not only geography, but even time. So there are many, many different ways of separating everybody geographically or by time. So as we have experienced, and as I can see, 10 out of 12 people have been experiencing distance simulation or telesimulation during the time of COVID-19, it is important for us to really think about how can we create an appropriate learning experience online. Because learning consists of many different factors. So first you can learn through listening and speaking, and then listening, speaking, and doing. I would say that the doing part is quite challenging using distance simulation. Certain doing tasks are really challenging during distance simulation. We have overcome them by sending equipment for task training to different locations. Many skills can be done by thinking them through. A lot of algorithmic or pathway-driven simulations work really well for distance simulation, and some are more challenging. The debrief is also something that we really need to consider. As we all know, we complete our learning objectives during the debrief. It is very important to talk about not only skills, but also the medical content. The debrief needs to be adjusted to the distance environment. And there are a lot of research projects currently going on to evaluate and elaborate how to best adjust the debrief to your distance environment. I hope that today in our different breakout groups, we can talk about the debrief at a distance for a moment as well. So now we will discuss the different platforms. One first will be Simbox or Telesimbox, in this case Telesimbox, Annenberg Hotkeys, and the virtual resuscitation room.
And we're going to do another quick poll and just see if any of our participants have actually used any of these platforms as well. Very cool. So we have some people who may be familiar and can even provide some of their own tips and tricks as we discuss each platform further. So thank you. Close that out. So now we're just going to go through each of these three platforms, share a little bit more about them, and each one has a fun video too. So I am going to let Maybelle take it away.
Okay, so I'm here to share our experiences with developing the American College of Emergency Physicians Simbox Original, which was originally a concept set forth by the pediatric section of the college, and in a response to a request for more simulation opportunities so that we could provide information to the community physicians taking care of pediatric patients. And so in doing so, we wanted to put together a kit that had sort of everything in it. So like some of these instant meals, so ingredients, information cards, and some easy to use equipment. And you can see sort of what we did here was to initially send out a whole bunch of these kits, which contained the mannequin, information cards on how to run the scenario and debrief, and then as well as a debriefing guide, which included some pediatric information so that you did not have to be either a simulationist or a pediatric expert to run these scenarios. And so in doing that, we developed a video drill and created a website so that we embedded all of this information on the website so that this could work essentially as an app and provide sort of an off-the-shelf experience for people to just use in their emergency departments in situ. So then along comes COVID, just as we're rolling out this project. And at the very cusp of this, we had some requests for people to actually help co-facilitate from a distance. And thus our version of the telesimulation was born. So we shut down all operations in our institution. We weren't allowed to have any in situ or in the sim lab simulations. And so we just adapted this for complete virtual experience. I'm going to pass over to Liz now to explain what we did next.
Thanks, Maybelle. So I joined the Simbox team a little later. I came on during the pandemic, joining Maybelle Koo, Mark Auerbach, Samreen Bora, who is actually on this call today too, and several others of the original Simbox team. And I was really drawn to the Simbox because at the time I was a young sim facilitator working in Bush, Alaska. I had just left my job in Bush, Alaska. And I was easily able to go to this website and use the graphics and tools to run simulations where I was working. And folks there wanted to continue to run simulations remotely. And so now was a chance to go back to the Simbox team and try to transform the tool into something that could be used remotely easier. So the educational pamphlets on the Simbox website are merged into one document to fit facilitators with all levels of experience. So intended for novice to experienced facilitators. And they're posted to the website for access that you can download and print if you would want. These are curated evidence-based booklets that contain a case summary and schema of each simulation, a case progression page, that is timed to match the video progression and the critical action checklist for when you're debriefing. And for less experienced facilitators, there is pre-briefing and debriefing scripts and information pertaining to the medical issue at hand. These free sim-foamed documents link to foamed vetted pediatric topics also at the end to assure good quality and, more importantly, current diagnosis and treatment information. So Becca, you can go to the next slide. So during COVID, we updated these resources, added some tips and tricks to the website and how to run a remote telesim box. And now we're going to show you a video. And on this video, you're going to see, I'm the facilitator, and you're going to see two pediatric residents, Lizzie and Tanner, and they are verbally thinking out loud, suggesting things that they want to do, and I'm responding to them as they're asking for certain things. Meanwhile, I'm remotely running the YouTube video. So basically, we're just running a YouTube video with a start and stop function, and I'm rewinding the video if they're not meeting learning objectives of the case, specifically if they're not attaching monitors, if they're not adding oxygen to the patient, if they're not putting an IV and giving fluids, for example. I'm simply rewinding the video as they're talking through verbally and participating in the simulation, and those vital signs are just staying poor and not progressing to better. If they're meeting all the learning objectives, I don't have to manipulate the YouTube video at all. It just progresses to have better vital signs. So we'll go ahead and play for you now a sample of what the all remote telesim box might look like.
And I'll add, many of us made our children act in these videos since everyone was home during the lockdown anyways.
This is Mark's child.
You grab a bag mask and start bag mask ventilation. And Lizzie, can you do a primary survey assessing airway, breathing, and circulation?
Yep, I sure can. All right, so up at airway, the patient's airway looks unobstructed. He is not crying or gasping. For breathing, I'd use my stethoscope, listen to the axilla. Sounds like there are breath sounds bilaterally.
Yeah, I'm hearing bilaterally, just breathing a little irregularly on his own.
Okay. For circulation, I'd like to check central pulses and cap refill. How are those?
Looks like his cap refill is about 3 to 4 seconds, and I'm feeling good brachial and femoral pulses bilaterally.
Okay. And we'll work on getting access for him. He has none right now. In terms of disability, can we get a D-stick for him quickly if the nurse at the bedside could do that?
Yeah, I'll go and grab the IV, and I'm working on getting a D-stick here. Give me a couple minutes.
Yeah, can you grab...
So that just gives you a flavor of how the SimBox looks with all remote learners connecting. And we've used it with all learners and facilitators in person, all participants in person with one remotely connecting simulation facilitator / coach, and everyone remotely located like you just saw in that video sample. So to date, actually, as of today, the SimBox has been used over 6,000 times around the world. And we continue to try to evaluate the tool. Specifically, our evaluations have focused on perceived efficacy and feasibility of the use, and we hope future studies focus on actual behavior change and patient outcomes. So now I'll pass it along to the next presenter, Kyle Cassidy.
Hi, everybody. I'm excited to talk to you about Annenberg Hotkeys, which is a very easy to use and very simple distance learning platform that allows a facilitator with the input of learners to direct a movie on the fly with multiple possible outcomes based on the decisions those learners make along the way. So Hotkeys itself is just 2 directories. One contains, Hotkeys runs locally on your web browser, meaning that although it can run over remote meeting software, it doesn't need that function, and you can use it in the field with in places with no internet connection. And while you can use professionally produced modules for Annenberg Hotkeys, one of the really great things about it is how easy it is to create and add user-generated content that might be specific to your location, teaching practices, or equipment. And Hotkeys itself is just 2 directories. One contains the video files for the module, and the other contains the program file that run the program. You just double-click on this HTML file to start the simulation. And I want to talk a bit about making your own content, and then I'll show you a real-world demo. I want to talk about making your own content, since that's one of the advantages of hotkeys. You're not dependent upon what someone else wants to teach, and you can utilize your own equipment and people and procedures, and everything will be familiar. And as an example, let's pretend that Jane Austen wanted to make an Annenberg Hotkeys module from her 1813 novel, Pride and Prejudice. The first step of making an Annenberg Hotkeys module is to flowchart your sim. Most video simulations are what we call sequential access. They start from the same place and they push through to an inevitable conclusion, and learners watch passively. And this is like a novel too. Hotkeys allows your videos to be random access, meaning that things can happen in any order and there can be multiple outcomes or multiple paths to the same outcome. In Pride and Prejudice, Elizabeth Bennet attends Mr. Bingley's party at Netherfield, and she's set with some choices that affect everything that's to come. And this is very important because when flowcharting a scene, we need to look at two things: choices and outcomes. So at the ball at Netherfield, Elizabeth Bennet has a choice. She can dance with the dashing young Lieutenant Wickham or the grave and stern Mr. Darcy, who honestly seems like a bit of a jerk. And we may imagine a Netherfield ball where Elizabeth decides to dance with Lieutenant Wickham, and that goes well, and Wickham proposes, and eventually ditches her for Lydia. Or she declines and goes off to become a famous writer. Either way, end of simulation. So those might be two possible outcomes from that first choice. But of course, the great thing about Annenberg Hotkeys is that it allows you to, that makes it different from a video, is that you can rerun it and make different choices. So let's say she does dance with Mr. Darcy, and this is the path that everybody's familiar with. And later she's presented with another choice. After believing him to be completely incorrigible, he writes her a letter. Does she read it or does she burn it? So let's say she reads it and learns the truth. Darcy's always been a really great guy who's just way too honorable to mention it. But let's say she's fed up with him. She burns the letter and goes off to become a famous writer. So these are all outcomes that you could have from this story. And all that's required to turn this flowchart into an Annenberg Hotkeys module is to film outcomes for each of these choices, which you can do by yourself with your cell phone and your team. Or if you have an AV or an IT department, you can film super sophisticated versions of them. It doesn't matter. Just give them the proper file names and drag them right into that video file directory. And you may remember that two of the outcomes were the same, and you can use the same files for these. Hopefully all of your simulations head towards a happy outcome with a patient in recovery, but Hotkeys allows you to have multiple correct solutions and multiple paths to that solution. When you double click on the HTML file, Hotkeys launches in your web browser and maps these video files to keys on your keyboard. Pressing different keys will launch a new full screen video. And it's like keys on a piano play notes when you play them. And so now I'm going to show you all of this in action. This is a Hotkeys module created by Dr. Ebor James at Valor Christian Medical College. He shot it with his cell phone. The simulation's being run by Liz. And you'll see the learners make decisions. And when that happens, Liz is pressing a key on her keyboard, which is trigger a new video file. So the narrative that they see unfolding in front of them is seamless, and it's based on the decisions that they've made.
More breaths on his own.
Okay, do we have anything up on the monitor yet for vitals?
Yeah, it looks like his heart rate's about 160. He's breathing about 60 breaths a minute. The temperature probe is showing a temperature of 38 degrees Celsius, and his SAT's about 91%. And that seems to be going up on the 90% on the non-rebreather.
Okay, all right, that's great. While we're grabbing things, can we get the Broslow just to measure? I think we're going to need a weight for the baby. And as soon as we have access, I'd like to get fluids going.
Absolutely. I'm going to go ahead and try for an IO because I really cannot get an IV. He's really clamped down.
Okay.
And once I get the IO, what do you want me to go ahead and start with? What should I have?
Let's do 20 per kilo of normal saline.
Okay. And how do you want me to give that? Over 30 minutes, 60 minutes?
No, let's push pull. And while we're at it, Tanner, would you be able to assess cap refill? And
yeah, I heard them say 5 seconds when he got here. As soon as the fluids are in, I'll check again and I'll let you know.
Great.
What it is. Okay, so I'm going to go ahead and give the 20 per kilo push pull now. And then as soon as we're done with that, I'll go ahead and reassess. What should I be reassessing for specifically?
I'll want to check the blood pressure. We'll reassess cap refill, and we'll just make sure pulses are still strong.
And that's that. I'll pass it along now to James and Alana, who are going to talk about the virtual recess room. Thank you.
Thanks for that intro and amazing work, Kyle. So with the VRR platform, this was developed in Canada. We took a little bit of a similar but somewhat different approach in terms of how we approach things. I will acknowledge that we actually have a number of people that are participating in our conference today that are also had a huge role with the VR, like Jabin as well too. So conceptually, when we designed the VRR, we wanted to sort of to emphasize 4 primary principles. These are actually very similar, I think, between the other platforms as well, but to lay it out on the table, we wanted the VR to really be a free and open access platform. We wanted it to also be simple and easy to use for participants as well as for facilitators, and also to be a collaborative platform. And specifically when we talk about collaborative, one big thing that we really wanted to emphasize was to allow individual team members to independently do actions on their own. Similar to what would happen in a real resuscitation, where you don't have to take turns per se in doing actions. And ultimately, we wanted something that was synchronous, that was responsive, and was live at the same time. So where one action would lead to a specific reaction from the actual simulation experience. So conceptually, if you take a sort of standard resuscitation type of scenario, where you have a sick patient that presents, a team that has to work to resuscitate the patient, and ultimately debrief and learn afterwards, what the Vrs Concept is to use 2 free, readily accessible softwares, which is Google Slides and Zoom, in terms of creating that simulation experience. The unique thing about Google Slides, in particular as this software, is this feature of live simultaneous editing, whereby if all participants have the same Google Slide document open, one person's actions can actually be seen on all the other person's screen at the same time and in real time. The other thing that was important, we felt, was to have some means of verbal and visual communication. Hence why we use, by tradition, Zoom, just because it was popular, but really any other video conferencing software would be applicable here.
So really what you do need is a laptop or any other type of device either a desktop computer or a laptop computer with internet and a camera. So ideally mobile devices aren't ideal because you can't look at 2 things at the same time, because you do need to look at the Google Slides and the Zoom together. So whether it's a laptop or a desktop would be great. So historically, we've always done this with group learners, either 4 to 6 learners and 1 to 2 facilitators. Ideally, you want the 2 facilitators because that allows one facilitator to pay attention to what's actually going on, and the second facilitator to help assist the team in what's going on with the actual case. So one actually watching the movements of what everyone is doing, and one person helping out the actual case. And this is, however, quite flexible. It is very possible to do it with just yourself. And the amount of learners is very variable depending on what your needs are, but 4 to 6 is the ideal group. So like we said, you got to get set up. So that's the first step. So you've got to get your computer, whether it's that desktop or laptop, and then divide yourselves into roles. And we'll talk about the exact computer setup in a moment, and divide into roles that we'll talk about in a minute. So there are various different roles, just like in any simulation, that you have to divide up for a team case. And then you actually get to run the case. So everyone really should have the same setup on their slide, and because there is no screen sharing. So like James said, everybody should have their own Google slide open because everyone is actually mobilizing things within the Google Slides, moving between their own slides, and moving objects in and out of the main room. So you can see this picture that we have here. There's that Google slide, which is the main room, as well as the Zoom that we put on the side. And the nice thing about the Zoom is that you can put it in gallery view, so you could still have a conversation with all your team members, just like if you were in real life, but now it's on Zoom or virtually. And so here's what we discussed earlier, is that that's the time to divide into roles. So there's so many team roles, as you know, during any simulation. So obviously you need your team lead, you need someone to take care of the monitors and the medication, someone as an airway lead, and history taker, procedures, and a runner. The one additional thing that's really important, we all have this in real life, is a recorder. Now, many simulations in general don't always ask for a recorder. For VRR, it is one of the key roles, and it actually highlights how important this role is in real life, having that recorder there. And we'll show you in a little bit on the video how important that recorder job is. And so here you go. This is, you're ready to go and share your case and run your case. And so here you actually have a setup where you have all your rooms. So you could see on the left-hand side of the screen, you have all those Google Slides ready for you to use. And then you have your main screen with the ability for the recorder to write notes and for the facilitator to put in all the information for the actual monitors.
So in terms of actions, essentially what we have learners and our facilitators do is really edit the slide together, and they translate again into actions that would be analogous to what would happen in a traditional in-person sim. Really, those actions essentially boil down to 1, typing in a text box, 2, clicking and dragging different items to represent actions or things being moved around, and 3 is copying and pasting. So finding one medication and moving it to another area. And although it seems really simple, because everyone is actually independently doing actions on their own, it actually replicates some of that in-person simulation experience we have, that organized chaos that in a traditional resuscitation simulation that we often see. So we've talked a lot about it. We have a small video that essentially the founder of the VRR, Dr. Sarah Fuhi, put together that can sort of show some of these features in action.
This all makes more sense when you see it in action. Let's check it out. Begin by applying monitors. Learners apply monitors by clicking and dragging the image of the monitor into place over the patient's body. As this happens, you can see the facilitator typing in the vital signs in the text box of the monitor on the right-hand side. Next, get access. Place an IV by clicking and dragging the IV over the patient. Difficult poke, you can show how to do an IO by landmarking and then walking through the steps of the procedure. Assess the ABCs and examine your patient.
If I take a look at his face and airway, what do I see?
If you go to slide 4, you can see a picture of what his face and upper airway looks like. And if you press play, you can hear an audio of his upper airway sounds.
Thank you. So Marley, I see a little boy who is awake and alert. He has some obvious swelling around his mouth and a rash on his cheeks. This is what I hear.
Manage your patient's airway. Click and drag the oxygen into place on the patient's face, then choose your flow rate. To grab extra airway supplies, go to the airway tray on slide 3, copy what you need, and paste in place onto slide 1. Organize at the head of the bed like you would in real life. If the patient's still hypoxic, you might set up high flow or type in the settings you need to start BiPAP. If they need intubation, you can see what your view is on GlideScope. Give medications. Go to slide 2, your medication tray. Copy the med you'd like, then paste it in place on slide 1. Drag it into the medications given box to show it's in the patient. Use machines. You can cardiovert your patient.
So oxygen, I'm going to take it off.
Excellent. So are we all clear?
Clear.
Yeah. I'm clear, you're clear, the oxygen is clear?
Point of care ultrasound has been integrated. Look at the image and describe your finding. Do procedures. You can do procedures like this Craig by clicking and dragging pictures of equipment and then using landmarking lines to show where you would make your incisions as you describe your steps. Let's see it in action with the perimortem hysterotomy.
I'm just going to make another vertical incision, just like a nick with my scalpel, then use scissors to open up the uterus.
We're at 2 minutes. Work as a team, divide into roles, and communicate clearly.
So Sarah, if you don't mind giving 8 puffs of Ventolin to this baby and let me know once that's been done. And if you could auscultate and let me know if his wheeze has improved, that would be great.
And just confirming that Benadryl as well as the ranitidine and methylpred have been given.
Thank you so much for listening to me share the virtual recess room. This all makes
So we've been really fortunate in having a lot of people use the VRR during this pandemic. As you can see, we've had people use it throughout the world. And last time we checked in May, I think there's been more than 22 different institutions using it. The original study to validate the use of the VRR has actually just been published in academic medicine. From a pediatric lens and a perspective, we've used it for a number of things throughout this pandemic. We've used it to replace in-person simulation learning. We've also used it to introduce new simulation curricula and teach that virtually. And that was targeting our postgraduate learners, our pediatric residents, and emergency residents. We've also used it to teach at conferences. Excitingly, I'm working with Jabeen right now to use it for outreach education to help improve the readiness of our community emergency colleagues. And finally, we've also been using the VRR for international education as well to network countries together.
All right. Thank you, everyone, for sharing these super exciting and amazing platforms. I know I've used them with learners locally as well as across the world. So it's been really fun to have these opportunities to reach out to people we might not be able to otherwise. So now we're about to get into the more interactive piece of the workshop. We're going to divide into groups shortly, and everybody is going to be given in their group one of these platforms to think about. And we are going to outline a simulation case. So keeping it simple, everybody is going to think about a case of SVT. You can titrate to whatever learner group you might work with specifically. And this is not to think about like the medicine of the case. You are going to think about a case where a patient arrives in SVT that is stable. They get a dose of adenosine, which doesn't work. They go into unstable SVT, which requires synchronized cardioversion, and they're better. So using that framework, we're going to think about what that case might look like. So most importantly, let's start with the learning objectives. Thinking about what can we achieve with the virtual platforms versus what you could achieve only in person. So an example might be, if I were running a simulation in person, one of my objectives might be demonstrate correct pad placement. And depending on what platform you're assigned, you may or may not be able to have the learner actually demonstrate that. So how might you change that objective so it could be addressed appropriately? We're going to write at least three medical learning objectives, and then think about one communication or crisis resource management objective. And then start to kind of outline what materials you might need to help create this simulation and embed in whatever platform. So are there particular images or videos or audio? What do you need to gather in order to start creating that simulation? And then finally, think about how communication is going to happen. You've heard that communication happens a little bit differently with each of these platforms, but how are participants going to communicate? How are facilitators going to communicate with each other? And then how are those two groups going to interact? So let's see. Let's take about 20 minutes in our small group. That'll get us right at 11 and give us some time. We're going to come back as a large group and debrief about kind of what we thought about and what our experiences were. And I'm going to let our tech gurus here open up those rooms. I'm muted. Welcome back, everyone. I think the groups are just starting to wrap up. Hopefully you got some time to discuss. I could talk about this stuff all day long. It's so fun to think about creating these sims, and I'm obsessed with learning objectives, so it's like my favorite thing to think about. All right. I think we're almost all back. So let's see. James, are you going to help run the Jamboard for us? Do I need to do anything for that?
Basically, click on the link and it'll open up the Jambox. I'm on myself, and then whatever you type, whatever people say, will show up on your Jambox.
Perfect. So I'm just going to go back real quick to these. So some things I would love to hear from the groups. What were some of the things that like surprised you, or some of the objectives you thought you were going to be able to achieve with your platform? And then also let us know any of the challenges you encountered or how you might have to alter sort of your objectives or what your plan might be compared to an in-person sim. We're a small group. Don't be shy. Feel free to unmute yourself. I see a hand raised. Ward Strickland.
Yeah, so that's part of the Simbox group. So we were talking about how, you know, in typical like in-person sims with mannequins and things like that, if we were having them like actually push a dance and having them use that three-way stopcock, that would be, you know, something they just show us and do and kind of explain as they're doing it. But in the virtual setting, we would have to actually just have them explain in great detail exactly what they would be doing. And if there was like a video that could go along with it, that would also be helpful. And then another thing would be like bagel maneuvers, you know, instead of like putting ice on the baby's face, having a video of that and, you know, being able to have the videos of the ECG changes with that too.
Great question, Ward. Thanks.
Yeah, that came up in our group too, the difference between being able to demonstrate something when you're in person or maybe using VRR versus having to verbalize how you would do something.
Another thing that came up in our group actually was kind of a little bit different. It was more like the communication side of things, you know, and how to communicate virtually while still kind of replicating that resuscitation room where like people can interrupt each other and ask questions on the side and things like that. Whereas in almost all the virtual platforms I've been a part of, it's very much one person talks at a time and you can't ask really anything else while someone else is talking.
Not necessarily true to real life, right? That one person talking. Thank you. How about anyone from the, oh, go ahead.
Sorry to interrupt. It looks like Simreen, who was in the Hotkeys platform, said that our group talked about the flexibility of branching points in the Hotkeys platform.
Yeah, Simreen, do you want to say any more about that, the pluses and minuses?
I mean, yeah, it's basically what I said there. Yeah, I think it's cool that you can have a variety of branches. And then you could also, we talked about how you could flex those branching points for different learning objectives and maybe even different settings, right? So there's a really great example of like, well, in one setting, in the same case, you know, in an international setting particularly, they think, you know, that there would be dengue fever, where in the setting where we initially created that case, that wouldn't be a thing. So the flexibility of being able to plug in like something else, right? The same case and not have to rebuild the whole structure of that.
I was in the VRR group and we talked about the ability to kind of customize the setting to be applicable to whatever resource setting you were in or what your hospital looked like for both medications and equipment.
Yeah, that flexibility is nice. We talked a little bit about shooting videos too with Hotkeys, and this would apply to Simbox too. You could, you know, shoot videos in your setting too to give that sense of realism. Feel free to type in the chat too. Anita can help share things that people share.
Just a quick reminder that we have 5 minutes left.
How about any thoughts around learning objectives or how communication might work with these different platforms and how that might translate or mirror real life or in-person simulations?
Our VR group spoke a little bit about that. Maybe I'll ask Geeta to speak a little bit about the communication thing, the challenges and the successes.
I can speak unless somebody else wants to talk from our group. So we did think about the communication, and we initially thought it was a challenge because there are too many people talking. There is one Zoom or whatever. But we also thought about the opportunities because in real life, it's difficult to say, yes, we say we have to have a closed loop communication is one of the objectives, but it's difficult to achieve. But in VRR or any similar, when you do on the web-based, you have to communicate, closed loop communication. Otherwise, we can't get the things done neatly. So we thought it's an opportunity to practice the communication and especially the closed loop.
Excellent, thank you. I know with VRR, one thing our group has done a few times with communication is moved some of the conversations out of the Zoom communication. And so I might portray a parent and have the learner actually call my cell phone and have that history gathering. And that I think has created a lot of realism, because that person gathering the history cannot pay attention to what's going on in Zoom at that moment. And so it really necessitates that like coming back together and sharing of information.
Becca, that's a great point. And we've done that in Simbox as well. If we have multitudes of learners, sometimes we'll have one of the observers actually fulfill that in the chat, like obtain the history. Because I think it is very difficult for the leader of the simulation to actually follow everything that's going on.
Christine Maloney brought up a good point of talking about needing to time to build comfort with the platform, like having the first case be a throwaway case, which has been really helpful. Joe McKittrick stated really clear instructions about how to communicate on the platform prior to starting.
Yeah, excellent points. There is, especially my experience with VRR, there's that getting used to it. And once you're used to it, it's so rich and robust, but people might get a little focused on like what button or how to drag and paste, copy, paste. Excellent. Well, we thank you so much for sharing. We are going to wrap up shortly. So I just wanted to share a few resources. Can you guys see my slides again? Yay. So good news for a couple of these platforms, including Simbox and VRR, there are actually already some cases created out there. So you can go find pre-made cases. Here is just a list of some stuff from Simbox. And there actually is an SVT case if you're wondering. And then with VRR, there are slide decks that are set up and prepared for many cases, including supporting documents. But again, this is very customizable. So you can go in and change the equipment or the medications to make it mirror your own environment. And all of that's free. I look forward to hearing how you all use these platforms to work with your learners. And thank you for joining us today. If you have any questions or comments, please let us know.